So I want to thank everybody that's online. I want to thank all those from Michigan that are here today. Let's hear a round of applause for all of you that are here. That's awesome. Thank you. So my name is Stuart, and I'm with MS Views and News, and this is a Compass to MS Care event. For those that don't know, we are sponsored by Bristol Myers Squibb, Genentech, Sandoz, and TG Therapeutics. Fortunately, we had a lot of exhibit sponsors, okay? So we have Alexion, Bristol Myers Squibb, Genentech, Horizon Pharmaceuticals, Infusion Associates, Novartis, Sandoz, and TG Therapeutics. Let's give all of our sponsors a round of applause, please. So thank you for that. Dr. Cody is from Memorial Systems, Memorial Health, Memorial something, from Memorial Neuroscience, or something that's out of Owasso, Michigan, okay? It's very hard for me to even remember how to say this. But I do know that she's a fabulous speaker because we had her speak few years ago in Flint. I shouldn't say a few, this was right before COVID, all right? And we've been just dying to get back to Michigan to have her speak again. And so we are here, and I'm gonna welcome Dr. Cody to do this presentation with you. So come on up and take it away. Thank you.
Thank you so much. So thank you all for being here tonight. I'm happy to present. Hopefully there'll be some things you've heard, some things you've not heard, something that you'll learn, something that will be fun. We'll do some questions at the end. You can ask me anything. If I go too fast, tell me to slow down, and we'll get started. So when I was asked to give this talk, the email that I got kind of listed a bunch of different areas they were hoping I could touch upon. And so some of that's going to be symptom management. Some of that's going to be just an update on where we are with MS medicines in 2023. And then I always like to talk about who should be on someone's MS care team, meaning like when you think about who is your team of caregivers, who that should be. Because sometimes when I see people, they've not met some of the other people I would like to be involved. And so I just always like to make sure I touch upon, anytime I talk, who else should you be reaching out to come help make you be the best that you can be. So, some of the things that we'll talk about are fatigue and spasticity, both what it is and how to treat it. We'll talk about pain, and then the treatments and care team. So, fatigue, if you go to like a wikipedia.com or a formal definition, a condition marked by extreme tiredness and inability to function due to lack of energy. And that could be something that can be just popping up, or it can be something that is part of your everyday, not having enough energy. And that's different than sleepiness. So sleepiness, to me, tends to suggest that there is a medical problem with the quality of your sleep. Someone can be tired, but they may not be sleepy. Sleepy is I'm nodding off. If I'm left alone, I might be falling asleep. If I'm a passenger in a car, I'm nodding off when someone else, hopefully not you driving, when someone else is driving. And so those are different because how we think about them and how we approach them are different. And someone might have both. But as part of the history, I like to tease out what is the fatigue and what is the sleepiness. So fatigue comes from a lot of different places. And usually everybody has a little bit from a lot of things. It's never typically just one area that's producing the fatigue. So one place that it can come from is the MS itself. And I think about that in two ways. I have some patients who, when I meet them and they're not yet connected to treatment, they have a level of tiredness that I've often thought was linked to some of that inflammation happening in the brain that's not yet been controlled. And sometimes you can connect a patient to a treatment and they start to feel better. The MS is being controlled and some of that fatigue is lifting. And then some of that fatigue can come from old MS scars. So in our brain, we have a sleep-wake center. And if there's scars there, I think of it like you can't turn the light switch all the way on to wake things up. And you're just kind of halfway there. So scars in the brain can absolutely produce fatigue, separate from what I think is the inflammation that can happen in the brain. Medications is a big one. So medications might be necessary to treat symptoms, but whenever we ask the brain to do less of something, like less pain or less stiffness, we're sort of slowing it down almost. And as a side effect, sometimes we can see fatigue with that. So sleep disorders. MS people get sleep disorders more than a rate of non-MS people. So you might say, why are you asking me about my sleep? My husband has, a sleeping problem. I hear him snore, I'm fine. But just by having the MS, it really sort of functions as a risk factor almost. So the quality of sleep is hugely important, because if you're not sleeping, you're not resting your brain. And all sleep is not equal. Light sleep that you can be easily woken from, or shallow sleep, is not restorative. It's the deep, deep sleep where it's hard to wake someone up from it. That is the restorative sleep. If you're not getting that, you could sleep 20 hours shallow. It's not the same as getting good, deep, restorative sleep. And brains can't fire at full speed if you're not resting them appropriately. So, mental health challenges. Sometimes there's a lot of stress that comes with a new diagnosis of MS, or even unrelated that might have already existed. One of the really interesting things that they found is when they looked at medical records of people who were going to go on to develop MS, they were looking for different patterns in how they used healthcare as a clue that MS might be coming. One of the differences they saw was an increased incidence of visits for depression and anxiety. And I think that's because by that point, MS was already starting to kind of do something, already starting to simmer in those areas and make some of those disconnections. So malnutrition, this comes up a lot. You have to nourish your body. And there's a lot of easy to access foods, but it's not always the most nutrient dense foods. Or maybe you don't have a big appetite. Maybe the medications, kind of kill your appetite. Maybe you run constipated, so you're usually not very hungry. But making sure you're eating well and nourishing your body matters. Other autoimmune diseases, so sometimes it's not just MS, sometimes you get another one with it, right? You collect one autoimmune disease, more can be coming. Thyroid, lupus, rheumatoid, these different things. So sometimes that plays a part too. So you want to make sure if there's concerns, you're diagnosing these and also treating these other illnesses. Pain is so draining. If you're in chronic pain, it is just siphoning energy. That's one that I see quite a bit. Time spent sedentary. So one of the things that we know is the more you can move your body, the more you help wake up the brain. And it's a fine line, right? You don't want to overdo it and pay for it for 3 days after, but you also have to look for opportunities to try to keep your brain moving to help keep that brain awake naturally through any type of movement, really. And then the last one is can't say no. So a lot of people I see run a busy household. They're caregivers to other people. They have families that they have to take care of, and they always come last, and they don't know how to say no. And that's not one that I think gets discussed a lot, but it's one that I think is really important, is recognizing limits and recognizing it's okay to turn something down or to outsource it to someone else. Even though it feels like we should and want to do everything, we should incorporate others. It's okay. But that can't say no, I think, is something that I see quite a bit, MS and non-MS. And I think it's important that we learn our boundaries and set them. So how we manage fatigue is really based on what's driving it. So one of them is, if you are someone who should be on MS treatment, getting you on MS treatment to really try to control any of the inflammation that's happening. There are some medications that we can try, so call them wake-promoting agents or medicines, and they're to try to wake up the brain. And everybody responds differently. Sometimes we'll try them in a certain order. Each physician has their way they like to do it, but these medications exist. My personal experience is they don't last forever. You sort of get used to them, so they can be helpful in the beginning and they can sometimes run their course. But stretched out, used carefully, they can be a big tool. Be willing to change your medication. So sometimes I'll meet someone and they're really, they have a lot of fatigue. And I try to go through the list to see, well, what else is contributing to fatigue? Sometimes it's heart medicines or, other medicines. And it can be tricky to get somewhere if there's not some flexibility in trying other combos of medicines to try to find a different way to treat, but still, manage the symptoms, but hopefully cause less fatigue. Healthy sleep, I kind of nagged you about already. And then the healthy relationships and treating any depression or anxiety. So one thing I wrote on there is I wrote use of a DMT. That means a disease-modifying therapy, which means an MS treatment. So nourishing your body, we talked about, healthy nutrients, healthy diet. Don't ignore your general medical health. You still have to see a doctor. Other things still happen. You can't just assume everything is MS. A lot of times it might be, but not every time. So you can't neglect your health. Learn to say no. And the last one I have on here is CBD. So there's an interesting study that's going on right now looking at giving THC, CBD, a blend, and really measuring quality of rest and daytime activity levels. So I'll be excited to see how this one pans out, to really look at some different ratios and doses to see is there value in trying to incorporate this for fatigue. So spasticity will be the next thing that we talk about. And it is a motor disorder characterized by velocity-dependent increase in tonic stretch reflexes resulting from an upper motor neuron lesion. Super clear, right? Super easy. So this is how I think about it. And this is a lot of the words that people use when they're talking about how they feel. And someone might not know that they have spasticity, but these are the buzzwords that when I hear them make me think, I bet there's a scar somewhere causing things to tighten up and hurt. So tight, squeezy, stiff, achy, heavy, sometimes sludgy. People will tell me it feels like they're trying to move through mud and they're having to fight to move. Cramping, sharpish pain, a hug or a real tight squeeze around the torso. A pulling, like my muscles pulling on me, or just, I don't know, it just hurts and I'm tired. I hear it from a variety of different ways of explaining it. And in a variety of different areas in the body. It could be in the neck, it could be in the throat, it could be in the torso, the arms, the legs. It could be on one side, it could be on both. But those are the words that when I hear it make me think, okay, I probably have to treat spasticity. Another way that spasticity can present that people don't often connect are these symptoms up here. So the first one is called clonus. And clonus is that fun trick where when you bend your foot up, the toe part, your foot does that bouncy thing really fast. Does anybody know what I'm talking about? Where it kind of jiggles? So that's clonus. Adduction. We have two muscles in our body that connect here to the inner knee, and their job is to pull our knees together. So one thing that can happen over time is our legs get closer when we're trying to walk, so much so that they might also actually cross in front of one another. That's those tight muscles pulling those legs together. Decrease in range of motion. So if something's tight all the time, at some point it might be hard to really stretch that open. Contractures. That's where when things are so tight for so long that really the structure of the tissues supporting it have changed and tendons have tightened and things are now permanently held in that position. Other joint problems. If muscles are pulling when they're not supposed to, it starts to hurt other things, right? If your leg is pulling, it's going to start to hurt the other hip and the other knee, and it sort of snowballs. So sometimes pain on the other side is indirectly related to the spasticity on one side. Urinary accidents. The bladder is a muscle, so it can be spastic or crampy like any other muscle. You actually have two muscles. You have the bag that holds the urine, and another muscle, which is the door of the sphincter. And if the bag squeezes because it's cramping when you didn't ask it to, you got to go right now, and you might be having an accident. If the sphincter or the door doesn't open when you've asked it to, you're sitting there waiting to pee, and you're waiting, and you might be pushing on your bladder to get it out, but it takes some time. And then constipation. So just like we have a door for the bladder, we have a door for the bowel. And if those muscles don't relax, then things can get backed up. So you may not necessarily think my urine is related to spasticity, but sometimes it is. So how we treat this, there's a couple of things. And I actually love that Mindy went first because stretching is such a huge part of this, right? So the point of stretching is we are telling those muscles to lengthen, because the signal to tighten is not under your control. It is unmasked. The brain is doing it on its own because a scar has interrupted the ability to stay loose. So coming out is tightness. And so you have to take that time to think, I need to stretch this limb, I need to stretch this muscle. Because if you don't, it'll just get tighter and shorter over time. So it matters a lot. And some people can be a good candidate for bracing. There's a particular brace that I like that people can sleep in, and over time it can help to slowly stretch open the fingers, so that if you're waking up with a tight hand, it's called the Saebo hand stretch. S-A-E-B-O. And it can slowly help open up those hands over time, so you're treating while you're sleeping. One of my favorite things to do. Medications. So first line tend to be muscle relaxants, because usually people have spasticity in more than one muscle. If you take a medicine by mouth, you're really treating the whole body. And there's a couple of those, so Flexeril, Baclofen, Tizanidine, sometimes Valium. There's a list. I can never predict who is sensitive to what. I can't predict on age or size or gender. Some people can take a lot, some people are lightweights and you can't even take a little bit. But medications play a big part of trying to treat these symptoms. And then Botox and IT pumps. We'll talk about both of those on the next slide. But then the other thing is to get help for it, right? So there's things you can do, and then there's things that can be done with you. So having someone else who's trained help stretch you or help show you the exercises, spending time with physical therapists, occupational therapists. You can get spasticity of your speech muscles. So speech therapy sometimes can be very helpful. I love a massage. Never hurts to get one of those. Acupuncture is another option. So these I wanted to talk about separately because these are things that people haven't always heard of when I'm seeing them in clinic. So the first one is Botox. And this is the same Botox as like Real Housewives Botox, right? Like smooth foreheads, crazy eyebrows Botox. You can put it a lot of places. What Botox does is it really helps, in a sense, paralyze the muscle for about 3 months. And we're not paralyzing it into nothing. We're bringing down that extra stiffness to make it more balanced with the rest of the muscles. And so we're very careful in where we put it. When this works really well is if there's a few muscles in particular that we have to target, right? So if we're targeting one leg or one arm or both feet, I have a lot of people whose toes curl under. I love Botox in the feet for that. It can just flatten those toes out, take away a lot of that pain. And it's done by a needle. So you would come into clinic, we mix up the Botox, you lay on the table, and based on what your exam tells us is where we place the Botox. Doesn't take long to do, doesn't hurt a lot. A little poke and you're done. Most people, if it works well, they're happy to go through it again. And it lasts about 3 months. This is an example, the pictures of some of the different ways you might see spasticity affect a part of the body. The one I see a lot is that one in the bottom left. Yes, bottom left. The equinovarus foot. That is a fancy way of saying a foot that does this. So it kind of turns in and it kind of points under. And we can do Botox right on the inside to help straighten that out. The next one is called an IT pump or an intrathecal pump. This is when So I think about these if someone has a lot of spasticity through the whole body that we have to treat and the medications aren't cutting it, either because they're not enough or they're not well tolerated. So what this is it's actually infusion of medicine right into the spinal fluid. By putting it right where you need it to go, you can get away with a much lower dose because you're not swallowing it by mouth and it's going through the kidney and the liver and getting metabolized. So you can control it, and you can control the dose really well. So it's a small pump or like a reservoir that's under the skin, and a small little catheter snakes around into the spinal fluid. Sounds crazy. Works quite well in the right patient as another way to really fine-tune treating spasticity. So, quick question to wake everybody up. True or false, pain is not a part of MS? Question, how many people in here have been told MS doesn't cause pain? Has anyone in here ever been told by their doctor, MS doesn't cause pain? Because I feel like I hear that from people. They'll come in and they'll say, my doc said MS doesn't cause pain. I'm sure they said it. They probably just didn't know what to do, is my best bet, or how to help you. So pain in MS, it occurs for a variety of reasons, right? And I wrote from your cortex to your toes. So you have an area of the brain that can produce pain, sensory pain area. Nerves can get damaged along the way, separate from brain and spinal cord causes of pain. Muscles can hurt, that can be a source of pain. If you have skin breakdown that's happening because you're not moving as well, that can be a source of pain. Bladders can be painful. Pain can come from a variety of different places, but it's not always coming from the same source, which is why treatment can sometimes be a little tricky. We don't have one good option for every type of pain. That's where we have to think a little more about the qualities and where we think it's stemming from. So some of the medications can act on the nerves if the nerves are causing pain, and that might be a zippy, fiery, prickly, electric-y, hot, burny, sandpaper kind of feeling. It can act on the muscles, which is that spastic pain. It can act on the muscle linings, and this is a newer area that's being understood. The muscle linings are like the skin of a sausage, like the casing. And I think we used to think that was kind of a throwaway body part, like the lining of the muscle. But we now know that there's a lot of innervation to that area, meaning there's connections to it. And the surface or the lining can also produce pain. And usually it can be a tenderness or an achiness. But because everything has a lining, it's also why you might hurt, you might poke somewhere, but you feel the pain somewhere else. And it's sort of hijacking that lining system to transduce that pain. So you might feel it here, but you're like, gosh, it kind of stabs up here when I do that. I often think that that's related to the muscle linings. Neurotransmitters, we have those in the brain. They produce pain. We use meds to try to knock them back to where they got to be. And then I wrote the EC system. And EC stands for endocannabinoid, which is this system in the body that we do not understand well yet. But this is the whole, like where CBD taps into or where marijuana taps into is this EC system. We're learning more. We're still like in the dark ages a little bit with it. And one thing that helps me is whether or not the med I give you helps, right? So if you respond to it and I know how that med works, gives me a clue where the pain is coming from. And if that med doesn't work, also might be a clue that I've not identified where the pain is coming from correctly, and I should try a different approach to things. So types of pain medicine, some of this is over-the-counter stuff that people have in their cupboards, Tylenols, Motrins, muscle relaxants we talked about. Nabiximols is this component from marijuana, and you might have heard of Sativex. Sativex is a spray, like a spray liquid for spasticity, but it is only available in the UK. So sometimes people ask me about that, but that one is not available in the States. Tricyclic antidepressants, Basically, those help sort of massage neurotransmitter levels and try to rebalance things to reduce transmission of pain. SNRIs, same concept, kind of working on those neurotransmitters. And then anticonvulsants. So all of these are first and foremost seizure medicines. But if you think about what a seizure medicine does, it helps block electrical activity that's not supposed to be happening. And so we borrow those properties to try to prevent those surges of nerve pain or electrical pain that can occur in the body. And then opioids. You won't see this one used quite as often. Usually for neurologic pain, we really lean on the other classes, but there are times where we'll see that be involved as well. So other things that help pain, because I think this is a really important slide. It's never as simple as take something by mouth. You really have to come at pain or any symptom from more than one angle. You have to just chip away from every direction that you can. And some of these are tools to help you do that. So movement, super important, especially for that muscle lining pain. We now know that the more you move to keep those linings supple, the less they will hurt in the long run. Same thing with spastic pain. We want to see movement. Not so much that you're hurting yourself, but it's important. It helps send the right message to the brain. Massage, love it. Meditation or mindfulness. And there's people who either can teach you how to do this or resources online, but really sort of trying to change thought patterns about pain or any other symptom. And I mention on here fight or flight because you've all heard of fight or flight, right? So the other half of fight or flight is submit and stay. Fight or flight is that burst of adrenaline when you gotta get away because you're about to get eaten by a saber-toothed tiger, so you gotta run. That's protective and it's helpful. Submit and stay is when you can't escape whatever that threat is and you're trapped facing it all of the time. So it's fight or flight, but gone wrong, and it's stuck. And what that can start to do is really change how your body is interacting with whatever symptom. It can start to turn a brief symptom into a chronic symptom and make it harder and harder to treat. And so I mention that because even if the symptom started however it started, the submit and stay phenomenon can make that much harder to break without trying to tap into some of these other ways of treating pain. Dietary changes. I have a lot of people who, when they cut sugar, they feel better, less burning, like refined sugars. I was never taught that, but enough people have told me that I very much believe them. So sometimes what you eat can manipulate pain. CBT, or cognitive behavioral therapy, is something that is done with a specialist who's trained in it. And it's, again, another way of trying to retrain how the brain thinks. And biofeedback is a cool one. So that's where you have sensors and you are doing Jedi mind tricks to change the sensors, like heart rate, blood pressure, temperature. So it's really trying to tap into the data of your body and watch you practice using your mind to change these metrics. It's a real thing, and it's why I give so much credit to mindfulness, because you can literally think your body into a different state. And if you can tap into that, that's powerful. Music therapy, that's a big one. I sat through that last wellness talk that Mindy did last year. There was a girl who talked about music therapy. It was wonderful. She had this song, and the rhythm helped with walking. That beat brought that step with the walking. It was genius. I never thought of this. So smart. TENS units are those devices that you'll stick on yourself, and they'll emit a little electrical tingle or current. And part of the idea of that is by creating that sensation, you're training your brain to feel something different. Spinal cord stimulation is something that continues to be looked at. I don't think we've still identified who the best patients for this are, but that's where they, in a sense, put a nerve stimulator right into the spinal cord area, so under the skin, to give those signals. And then there's a lot of interesting research that's starting to happen looking at ketamine, the drug, and psilocybin, which is shrooms, for pain. And I actually think that's going to turn out very interesting when that gets done. So what I also wanted to touch upon is where we are with MS treatments. So if you look at this board, we started in the 1990s when treatments first were starting to come to market. And there's like not a lot of letters. And then a little bit more, and then I put a line here because all of a sudden, right? So much has happened from 2010 to 2023. And one thing that's also happened is the medicines have changed over time. As we understand MS better, we understand where should we intervene in the pathway to get the most bang for our buck. So not only do we have more medicines, but they can offer more benefits to patients. All of them will reduce risk of relapse. Some go as far as trying to prove that they help hold on to brain volumes, reduce fatigue. All of them are really trying to show what extra they can do. But the nice thing is treatments nowadays come into market, they deliver. They deliver on treating MS well. What they also do, in my opinion, is come with a very nice risk profile relative to what you're getting for them. A lot of these drugs have head-to-head trials with drugs on this side of the board, and the side effect profiles don't look very different for a drug that might deliver 2 or 3 times more to you. So to me, I'm not a mathematician, but like that to me seems like good math. And sometimes when you look at these drugs, you can read scary things written about them. Ask your neurologist. They'll give you their honest opinion. They should. About how they think about it, have they seen it, what their concerns are. There's never a question about treatments we don't like to be asked. One word on this slide that you'll notice is the word generic. It wasn't until, I think around 2015, that we had our first generic. And coming after this is going to be something called biosimilars. And this was something that Stuart wanted me to touch upon tonight to kind of give everybody an update of what these things are and how they might affect things moving forward. So to back up, we have regular drugs and biologics. Regular drugs are what you would think a drug is, right? Like a Tylenol or a Motrin, a medication. And then there's a class of medicine called biologics that's developed over the last number of years. And that is a drug where the active ingredient comes from a live agent. So human, animal, or microorganism. We classify these as biologics. And you'll notice interferons are on there. Interferons are ancient. They were like one of the first things we had. So biologic itself is not a new, 2020 technology. What we also then have, though, after drugs have been on the market long enough, are the copycats almost. So generics is a good example. So if you've ever anybody seen Breaking Bad? Maybe, yeah, Heisenberg cooking, right? So he is producing, I want to say it's meth or something. He's producing a drug, right? But it's chemical manufacturing. These are easy drugs. It's like baking a cake. You're making a medicine. That's a generic, right? So you're getting the same. Anybody can follow that formulary to make a simple medication for you. Biosimilars are different because you're deriving your active ingredient from a live type of material. It's not going to be totally identical every single time. But biosimilars have to be rigorously studied, and they are essentially as identical as possible to the actual biologic drug. And we have our first biosimilar that's coming. So that's why I mention it, because when these things come, insurances tend to make that switch whether you've asked them to or not. The other time this pops up is when generic drugs come to market. Sometimes when people are on they're on brand, and their insurance will switch them to generic without being asked, and all of a sudden they get a bill because the copay plan now doesn't cover for the generic. It can be kind of tricky. So generic, brand, biosimilar, these words, they matter from a logistical standpoint, but I do think biosimilars are something that we shouldn't be afraid of. I think those are going to be an okay adoption. But we'll watch with a lot of caution and make sure that we like what we see. And then emerging areas that at least I'm keeping an eye on. So one is something called BTK inhibitors, and this is a new MS treatment. It's in phase 3 clinical trials. It's a pill, and it's different. So this will be a new mechanism. Some of the meds that we have are sort of spin-offs of older medicines. This will be new. This will be new to the bunch. And what might be special about this is it might have a better ability to penetrate into the brain, which is one area that's hard for us to get to with current medications. Stem cells is another area. There's a fascinating study right now looking at stem cell transplants versus best of the line treatments. If stem cells do better than best treatments, Ocrevis's, Kesimpta's, Tysabri's, Lemtrada's, these types of sort of best-in-class, Briumvi, another B-cell. But if stem cells outperform these medications, that's going to be a huge step in making this more accessible for people. And I can't say it's appropriate for everybody, but there are patients where it is something that could be offered in the right circumstance. And so I think any data we can get surrounding any treatment that can really help people forever would be wonderful. And then the last area is also, when can we stop treatment? So we talk so much about treatment. Get on treatment, take your treatment. But like, when do you get to stop it? And so that's another area of focus of, can we identify factors about people that let us know they're probably at a window where they can stop their treatment and it's okay. They've invested enough time that they can retire from it. So that'll be something coming out in the years to come that'll also be interesting data, I think. And then last thing I wanted to go over are people who I think of when I'm creating a care team for a patient. I put the MSologist first. That's a newer term that I've seen used recently. And that may not be the same as your neurologist, right? So I have some patients who live far away. They have a local neurologist. They check in with me once a year to just kind of green light the plan that's in place. So you might have both, an MS doc and a neurologist. An MS nurse, so valuable. Physiatrist, this is like a body mechanic. So their whole field of medicine is helping your body work well. They focus on muscles and tendons and joints and like keeping you functional. Most people have never heard of this field of medicine. I think everybody should have one, MS or no. Like, I just think this is the most important field that could be part of anybody's care. Primary care doctor, you have to have one that you like and you trust and you can go to with questions. Your MS doc is not going to know everything. You're going to need a good primary care. Other specialties, I refer a lot to urology, to psychiatry, to sleep medicine. MS pharmacist, shout out to Michael in the back, who is our MS pharmacist at Memorial. He came tonight to learn more, so thank you. The therapist, PT, OT speech. Neuropsychologists, these are people who can help analyze how your brain is thinking. You know, you might notice some word retrieval, word hunting. Maybe you get scattered trying to do chores in the day, like which one am I supposed to be doing first? These are people that can come in and help me understand how your brain works and how we can play to your strengths. What's the best way to deliver information that it's easiest for you to receive? How should I not communicate? Because maybe that's not your best way of me telling you something. And they can also keep track of how brains do over time, which can be helpful as I'm watching people's response to treatments. Support groups, advocacy groups, and family and friends. And family and friends shouldn't be last. They're very important. They're last on the slide. But your circle really matters. Having people around you that you can talk to, that you trust, that can see you at your worst and still love you despite it. And then ways to maximize care, because not everybody has an MS doc near them. Some states only have a couple, and there's a lot of people in states. Michigan, we're lucky that we have quite a few scattered about, but many states aren't as well equipped with MS docs as we are, actually. So ask for an expert, though. If you have a general neurologist, you can still ask them to refer you out for an updated opinion. Sometimes I see people for a one-off, one-time opinion. I sort of give a short-term, long-term sense of goals, and they take it back with them, and that works. Telehealth, so now that COVID happened and we have virtual visits, it's a way to patch in with an MS doc who might be 10 hours away, but to have them take a look at your case. Social media can help you find people. Some social media is scary. Some social media is good. You just have to kind of look and find your tribe. And then loop your doctor in. So they should know what's happening. Like I had a doc call me today and he was like, you made a med change. You didn't tell me. I don't think I like it. And I'm like, whoa, thank you for calling. So you want a doc that cares. You want a doc that is looped in and is willing to have those conversations because we want to talk to each other. The system's just not designed for us to do that easily. But we like it when we can talk to your other specialists. So a doc, keep the PCP in the loop because they can really help advocate for you too if a doc maybe makes a change and they don't like it. And then nourish. I always talk about mind, body, soul. It's never one thing. It's never just take your medicines or show up for your MRI. You have to treat your body well, you have to treat your mind well, and you have to nourish your soul if you want to really, I think, do the best you can dealing with this disease. So, my 2 cents. Any questions?
That's good. Everybody say thank you for this wonderful presentation. All right, so first person online, I'm going to ask his question first, and then I'll go to the audience, and then I'll come back. And Kevin wants to know why you did not mention anything about S1P1 DMTs on your slides.
So they were on that therapeutic landscape slide. I listed them under first-gen orals and second-gen orals. Orals meaning pills by mouth. In 2010, we got our first pill by mouth. And in quick order, we had 3, Aubagio, Tecfidera, and Gilenya. And then I wrote second-gen orals. And you're right, Kevin, that was not clear, so thank you. Second-gen orals. So this is basically people took the original product and they tweaked it, they refined it, they changed it, they made it easier to use. And that's been really exciting because some of those meds back in 2010 weren't always the easiest to be on. They might have caused upset stomach or you had to be babysat to make sure your heart didn't stop when you took them. Like, that's kind of scary. But the newer versions now, thankfully, have all been modified to really help us not have to worry about those issues near as much.
Okay, thank you. Now we'll come over here.
So up until recently, I thought that stem cells would be the end all of MS, but I'm going to use the more bigger buzzword now is AI. How do you think AI might be introduced to actually figure out what MS is and solve that problem? Or is that being discussed at all yet in the medical field?
I mean, there's definitely innovation technology-wise. So where I've seen advancements personally is really in devices focused on walking or treating sleep apnea through devices. I have not seen as much other areas of AI, but that doesn't mean it's not happening. It's just not something I'm totally up to date on.
Okay, so now can I add something about AI and MS stuff? So AI, there's a company named Icometrics.
Oh, yeah.
Okay.
We use, yep.
Right, and they're using AI technology on your MRIs. All right, so that way one day they won't need a radiologist to actually see what's wrong with you. All right, and it'll all be determined by the AI technology, and it's in such depth of what they're seeing is they're seeing your brain in so many dimensions that right now doesn't exist except on AI, and it's pretty amazing. I mean, I've seen it. I've seen examples of it from this one company, and there are other companies out there that are starting to get into this as well. And it'll be better for your doctor to understand really what's really old compared to what's possibly new.
So I will say we have that type of technology as part of our MRI scanner. So if you've done MRIs at Memorial, you have this data. You may not have been shown it or told about it, but you have this data that can be printed and given to you.
Okay, thank you.
So 5 or 6 years ago, pre-COVID, when I would start doing some research and listening to seminars on different DMTs that was available, oftentimes they would rank the medications as far as for, like what I want to say, like you waited to go with the big guns until you needed them. You tried everything else first. And I recently read an article that said that that's not necessarily true anymore. They like to just start you right off on the big guns. So that would be my first question. So if you did start right off on the big guns and that didn't work, then is there a bigger gun?
I like it. So I think we got it wrong in the beginning, but we also did the best we could with the therapies that we had. When I was in training, they gave me this book, and it was a book of like how to do MS. And on it said things like you could get X number of scars before you had to change medicine, or you had to wait certain benchmarks before you could do something else. And I remember thinking, well, that's weird. Why do I want multiple scars before I change? If something's not working, why am I not just changing? And it was a very reactive culture. It was slow to diagnose, years between relapses before you might diagnose, maybe slower to start treatment, and then escalate if someone failed. But at the time, that was how they approached it. As we have learned more, we now know that we had that pyramid wrong, and it should have been flipped upside down. And I think for a couple of reasons. One, we actually now have data that looked at starting lower efficacy medicines versus higher efficacy medicines. And some people call low or high as like big gun is like a high one. And we have data now that looks at starting with one or the other and tracking over time. And within years, we see differences in disability. And you don't catch up, which really speaks to the importance of starting that early high efficacy therapy. My other personal thought is if you're thinking about risk, meds are easier. All-nighters are easier when you're 20, and they are harder when you're 80. If you're going to take something on, surgery, anesthesia, these things, when you're younger and have less other health conditions, that's the time to be investing. And as you age, you get to pull off and enjoy the results of what you worked hard to protect. So I think thankfully as the new generation of MS docs are coming out, we really look at the pyramid in a different way. And it makes me really hopeful that for years to come, we'll just continue to really expect a lot out of MS patients, because I think the other way, the expectations were low, and my expectation is full lifelong life, and I think if we keep that pyramid where we start with that high efficacy treatment early, that's what we push for.
Thank you.
Okay, I wanted to make a statement. First of all, I'm a patient at Memorial. I wanted to tell you it's a very beautiful facility. And I did have an MRI, and I got the results like within an hour, outstanding. And I had another comment. My comment was you touched on when you retire a drug. I mean, what age about you will get to when you're ready to retire? I mean, I've had MS for about 30-something years, and I feel like I've been on every drug you've had.
Yes.
And I want to know, is it eventually a time where I could just stop? I have talked to some people who was older than me with MS, and they've completely stopped taking anything. But I know that's between me and my doctor. But
yes.
I was just curious to know if you had an impact on a statement like that.
And this is often a very surprising statement when I tell patients a time will come where you're all done. Because I think people have understandably thought I do this my whole life. But what we know about MS is it really tends to cause flare-ups in the beginning, scars in the beginning. And over time, there are day-to-day symptoms, and they might change year by year. But MRIs tend to stay stable, and they're sort of a good day, bad day, fluctuating baseline. But usually those big dramatic flare-ups that led to diagnosis in the beginning, they sort of stop happening. And we actually have data tracking people like natural history data that shows this. And so what we're thinking in our heads is, what is someone's risk of relapse balanced to risk of problem from the medicine? And we take into consideration when they were diagnosed, when their last relapse was, what their symptoms are, their MRI, what are their other health conditions. So it's not always like a perfect when you're 65, you do this. Although some countries have guidelines like that, where when you hit an age, you can be done. I think we'll eventually get there with our own guidelines. In general, though, when someone is approaching 65 is when I start to have a conversation. Doesn't mean I'm ripping meds away, but I'm starting to have a conversation. And there's always exceptions to that. If you ask any neurologist, they'll have their oldest patient that ever relapsed, memorized. So there's always exceptions, and it is a personalized conversation, but it is a conversation. These are not things that you have to do forever.
You spoke earlier about restorative sleep. how much restorative sleep? Out of a night's sleep, what would you say should be restorative?
So people are genetically different on sleep needs. There are some families that only need a couple of hours and they function fine. And there are some that genetically need more sleep. So in general, though, we want someone to have good quality sleep, 7 to 9 hours a night. And good quality sleep means you start and you get deeper in sleep, and then you lighten up a little bit, and then you get deeper in sleep and you lighten up. And when you watch it electrically, you see these beautiful waves. And so 7 to 9 hours is a good rule of thumb. If someone's getting 6 and they're tired, my first thing is for them to try to get more hours of sleep. The other thing is napping. You have to be careful with nap duration. So if you're napping a couple of hours, you're going to mess up with your sleep cycle. So you want to, as tempting as it is, you got to keep them shorter. Like 30 to 60 minutes is a good duration. When you start to get past that, you start to run the risk of messing with your sleep.
Hi, Dr. Cody. We miss you.
Hello.
My question is a little bit off topic, but has there been any advancement in the investigation of therapies to reverse or repair?
Yeah, so remyelinating, we call that remyelination. And it's always being looked at, but as far as really in the pipeline, like phase 3 clinical trial, we're not quite there yet. There's a lot of money being put into it, though, and I think whoever's first, will change things for a lot of people, but we're not quite there yet.
I just wanted to ask you a question about, you said a neurologist, and then you said something about a MS doctor. I didn't know it was even a difference. I thought It was just a neurologist, period. I need more information, please.
Yes. So within neurology, you can specialize in lots of different areas: seizures, dementia, movement problems like Parkinson's, and one of the areas you can specialize in is MS. So one thing that has happened is the MS medicines have exploded. So if you trained a long time ago, you might be great at staying up to date on stuff, or you can look at these and say, I'm going to stick in my comfort lane. I'm going to stick with the ones I like, the ones I know, and if there's a problem, then I might refer someone out. But there's now a whole field of MS neurologists. And so basically, after I finished training, I did an additional year just learning MS and things like MS. And then I've just been doing that ever since. So they do exist. And I do think with how complex things have gotten, that patients really should have a chance to speak with one at any time in their journey.
Okay, question from online I'm going to ask you. Are there this is from a Cindy. She wants to know if there are any updates on BTK inhibitor, when it will finally get FDA approved. And she writes, it's been in 3rd phase trial for a long time.
Correct. So at Memorial, we actually have a few, we're involved with a couple of the BTK trials. So if someone's eligible and interested, we might have early access for you because we have those clinical trials. But we're still enrolling. So it's still going to be, I would say, at least a year before we get a better real like FDA approval kind of projection, but we're still a little bit away from that for sure. And there's also multiple companies developing their own, and so the first one to come might be the best, might not be the best, but at least that's the next wave of therapies are these BTKs. I think right now there's 5 that are being looked at. What is it? It's a pill, and the BTK stands for Bruton's tyrosine kinase inhibitor. A guy named Bruton discovered it. And it basically it's like a traffic patrolman sort of telling immune cells how to behave and sort of putting his nose in a lot of different immune cells' business to make sure things are happening appropriately. And it'll be different than how the other medicines we have available work.
If you want more information on it, you go online. I mean, you just type in BTK inhibitor online, and it'll give you tons of information that's out there.
Super hot right now.
Right. And there was one, though, that there's only one in phase 3, and that was just put on hold. Do you know why it was put on hold?
So some people had an irritation in liver numbers, but we are going back in action soon.
Great. And the other BTKs, I mean, they're most of them are in phase 2, correct?
So we have a second one that just, Dr. Pace will be running that one that we're opening up pretty shortly.
Okay, great. Thank you for
Yeah.
answering that. All right, we have a person named Kevin who's asking something. I saw he had it here. And he said, please tell us more about the CBD THC study. Is cognitive function also being considered?
So this one is being done through University of Michigan. And if you Google clinicaltrials.gov, it's an active list of all clinical trials. And it's very easily searchable because you put words in that you want to look up. So you could say MS and CBD, or MS and THC, or MS and stem cells. And it'll pull a list of all clinical trials, who the contact is, where it is, who's eligible. Wonderful resource, clinicaltrials.gov. And this, you'll find this study on that website, but this one's being done through U of M by a Dr. Braley. And I know they're looking at sleep study data and actigraphy data, or like daytime movement data. I'm sure there's going to be some questionnaires looking at fatigue and cognition. That's the most that I know, though, about how detailed it might be, but that protocol will be online at clinicaltrials.gov to get more info.
Okay, great. Another person is saying that they were on THC indica at night and had to stop due to suppressed appetite. How could that happen?
Well, each strain will do different things. So if you go to a dispensary, you will be under the advisement of whomever is running the dispensary, and they will guide you to the best of their ability. Most people might look at indica to help with sleep, or sativa to help with alertness. And sometimes we think about marijuana causing the munchies and appetite, but there's actually a huge group of people who get recurrent nausea and vomiting related to regular marijuana use. So we see it quite a bit. We have some nausea centers in the brain. I have to think that the marijuana is acting there to produce it. But as much as you think it stimulates appetite, there's a group of people very susceptible where it does the polar opposite. And the only way to treat it is to actually get away from the marijuana.
Thank you.
I know that I'm 67 years old. I shouldn't be broadcasting that. But I thought that MS is a lifelong disease. And so I'm wondering now you're talking about possibly stopping the drugs. I don't know what I would do, because I got this new drug that I'm going to be taking. I don't know, I don't like that, but so it's an injection.
And it's really a decision. Your doc who knows you will know more about what your risk is coming off. But if a treatment is designed to reduce risk of relapse, and your personal risk of relapse is essentially as low as possible, then there may not be a lot of extra benefit being on a medicine. And this is something that we see as a phenomenon more with age. So it's, I really generally don't have 80-year-olds on treatment. That's not to say that people don't do that. But I think at that point, that risk for relapse is very small, and they get to be done. They get to take a holiday. But for some people, it can be a very scary feeling of like, what am I doing if I'm not taking treatment? But I think that's where you have to step back and think, for each individual treatment, what is it actually supposed to be doing, and do I still need it for that particular purpose? Doesn't mean MS is gone. Those symptoms that you have, you'll carry with you always, but it's that risk of relapse or a new scar that is diminishing, and that's really the primary focus for most of the MS medicines.
Thank you, Dr. Cody. We are finished. There's no more questions. So thank you very much for being here today.
Happy to come.
We look forward to
Thank
seeing you
you.
again. We definitely look forward to seeing you again, and maybe one day we could get up and closer to Memorial and do something up in that direction again, right? So for everybody that is here, I do want to thank you for coming out tonight. I want to thank you all for being here. Of course, we want to thank our sponsors for tonight's program, and I'm just going to say good night.